What would drive a veteran emergency room nurse with 12 years of experience to request a permanent transfer to a different department after just one shift? In today's story, you'll discover what happened during my final night in the ER at Metropolitan General Hospital and why I can never set foot in Trauma Bay 7 again. But before we dive into this disturbing account, make sure to subscribe to the channel and hit that notification bell so you never miss our latest stories. Leave a comment below telling us which shift you think would be the most terrifying to work, and watch until the very end if you can handle what I'm about to share. There are experiences in healthcare that fundamentally change how you view the practice of medicine. Moments that shatter your understanding of what's medically possible and force you to question everything you thought you knew about human physiology. What I witnessed on the night of October 14th has haunted my dreams for 7 months now, and only today have I found the courage to put these events at Metropolitan General Hospital. One of the bus recently, I was a registered nurse in the emergency department, Chen, and until name is Sarah Hiest Trauma Centers on into words. The West Coast. In my 12 years of emergency, everything from routine cardiac arrests to mass casualty incidents, composure under pressure, thinking nursing. I prided myself on maintaining rationally during compassionate care, even chaos, and providing being circumstances. I in the most distant had witnessed death, they say, in countless forms, held families asked goodbye to loved ones, and worked through medical emergencies that would traumatize most people. I thought I understood the boundaries of human medicine, the limits of what our bodies could endure, and the clear line between explainable medical phenomena and the impossible. I was completely wrong. Metropolitan General Hospital is a massive complex built in phases over the past 40 years, with the emergency department located in the newest wing completed just 5 years ago. Our trauma bays are state-of-the-art facilities equipped with the most advanced life support technology available. Each bay is identical in layout and equipment, designed for maximum efficiency during critical care situations. Trauma Bay 7 was no different from the others, at least not in any way that would be obvious to a casual observer. Same monitors, same equipment, same sterile white walls and fluorescent lighting. But the nursing staff had developed an unspoken understanding about that particular room over the years, a reluctance to assign patients there unless absolutely necessary. When I asked about it during my orientation, the charge nurse, Margaret Rodriguez, had given me a dismissive answer about equipment being temperamental in that bay. Other nurses mentioned occasional issues with monitors giving false readings or IV pumps malfunctioning, but nothing that seemed particularly unusual for a busy emergency department, where equipment runs constantly and takes a beating. It wasn't until my final shift that I understood why so many experienced nurses avoided Trauma Bay 7 whenever possible. October 14th started as a typical Friday night in the emergency department. I had been assigned to the trauma team covering bays 5 through 8, working alongside Dr. Michael Stevens, our attending physician, and Janet Walsh, a respiratory therapist with 15 years of experience. The evening began with routine cases, nothing that seemed particularly challenging or out of the ordinary. At approximately 11:30 p.m., we received word that paramedics were bringing in a 26-year-old motorcycle accident victim with multiple trauma. The patient, identified as Marcus Thompson, had been involved in a high-D collision SPE with a delivery truck on the. Initial interstate reports indicated severe head trauma, possible internal bleeding, and multiple fractures. Due to the severity of his injuries and the fact that our other trauma bays were occupied, Marcus was assigned to Trauma Bay 7. As the paramedics wheeled him in, I could see that his condition was critical but not necessarily hopeless. He was unconscious, intubated by the paramedics, and showing signs of significant blood loss, but his vital signs were detectable, and he, for his life, D to be fighting. Appear began his assessment while Stevens immediately I prepared the necessary equipment for trauma resuscitation. Janet worked to establish better airway management while we connected Marcus to our monitoring systems. Everything proceeded according to standard emergency protocols, and initially there was nothing to suggest that this case would be anything other than a challenging but routine trauma resuscitation. The first sign that something was wrong came from our monitoring equipment. Marcus's vital signs were displaying normally on our screens, showing a heart rate of approximately 90 beats per minute, blood pressure readings consistent with blood loss, and oxygen saturation levels that were acceptable given his condition. But Janet noticed something unusual about his breathing patterns that didn't correlate with what the monitors were showing. "Dr. Stevens, his respiratory rate doesn't match what I'm seeing on the ventilator," Janet reported. "The monitor shows 18 breaths per minute, but I'm counting closer to 30 spontaneous breaths." I checked the equipment connections and verified that all monitoring leads were properly placed. Everything appeared to be functioning correctly, but Janet was right. Marcus's chest was rising and falling much more rapidly than what our electronic monitoring systems were registering. Dr. Stevens ordered a complete set of arterial blood gases to determine Marcus's actual respiratory status, but the results only deepened the mystery. According to the blood work, Marcus's oxygen and carbon dioxide levels were exactly what we would expect based on the ventilator settings and the monitor readings. Yet we could clearly observe that his breathing was much more labored and rapid than what the numbers suggested. As we continued working to stabilize Marcus, more inconsistencies began to emerge. His heart rate monitor showed a steady rhythm around 90 beats per minute, but when I manually checked his pulse, I counted nearly 120 beats per minute. The blood pressure cuff readings indicated hypotension consistent with blood loss, but when Dr. Stevens manually palpated his pulse, it felt much stronger than the numbers suggested. Most disturbing was Marcus's neurological presentation. His Glasgow Coma Scale score, based on standard testing, indicated severe brain injury with minimal responsiveness. But periodically, Marcus would open his eyes and appear to track movement around the room with a level of awareness that seemed impossible, given his supposed neurological status. "Dr. Stevens, I need to show you something," I said, positioning myself directly in Marcus's line of sight. "Marcus, can you hear me? If you can understand what I'm saying, blink twice." Marcus immediately blinked twice, clearly and deliberately. According to every neurological assessment we had performed, Marcus should have been completely unresponsive. His brain scans showed significant swelling and injury that should have rendered him unconscious. Information and responding appropriately to complex. Yet he was clearly processing verbal commands. "This is medically impossible," Dr. Stevens said quietly. "His cognitive function that to demonstrate Marcus' continued brain injury is too severe for this level of consciousness." But defied I asked him to move medical condition. When his fingers, if pain, he was ingled the fingers on his. Stevens asked him to look uninjured hand. When doctor toward the door, Marcus turned his head in that direction, despite having injuries that should have prevented such coordinated movement. The most unsettling aspect of Marcus's condition was his apparent awareness of medical procedures that he shouldn't have been able to understand or observe. As Dr. Stevens prepared to insert a central line for better vascular access, Marcus became agitated, shaking his head and trying to speak around breathing tube. "Marcus, this need to put in. We to help you. I explain line IV. It's going to help us give you the medications you need," to the Marcus pointer a sound machine that Dr. Stevens was preparing to use for guidance during the procedure. He then made gestures that clearly indicated he wanted Dr. Stevens to use the ultrasound to visualize the blood vessels before attempting the insertion. This was a standard practice for central line placement, but there was no way Marcus could have known about ultrasound-guided vascular access unless he had extensive medical training. According to his identification and the information provided by paramedics, Marcus was a construction foreman with no medical background. "Dr. Stevens, he's trying to tell us something about the procedure," I observed. "It's like he understands the medical equipment and what we're planning to do." As the night progressed, Marcus continued to demonstrate impossible knowledge and awareness. He correctly identified medications before we administered them, anticipated procedural steps before we performed them, and even pointed out potential complications before they occurred. When Dr. Stevens prepared to administer morphine for pain management, Marcus shook his head vigorously and pointed to his medical bracelet. We checked the bracelet and discovered he was allergic to morphine, information that somehow hadn't been communicated by the paramedics. But Marcus had no way of knowing what medication Dr. Stevens was preparing to give him. Yet he had warned us before we could make a potentially fatal mistake. The situation became even more bizarre when Marcus began providing information about other patients in the emergency department. While Dr. Stevens was reviewing his chart, Marcus started making urgent gestures toward the doorway. He was clearly trying to communicate something important about what was happening outside Trauma Bay 7. I stepped into the hallway to see what might have caught his attention. At that exact moment, an alarm began sounding from Trauma Bay 3, where another critical patient was being treated. The patient there was experiencing cardiac arrest, requiring immediate intervention from the code team. "Marcus, how did you know that was about to happen?" I asked when I returned to his bedside. "You can't see into the hallway from your position, and there were no warning signs that would have indicated a problem in another room." Marcus looked directly at me and mouthed words around his breathing tube that I could clearly understand. "I can see everything." Dr. Stevens and Janet exchanged concerned glances. We were dealing with a patient whose medical condition should have rendered him unconscious and unaware. Yet he was demonstrating supernatural levels of perception and medical knowledge that defied every principle of emergency medicine. The equipment malfunctions that other nurses had mentioned about Trauma Bay 7 began to make more sense as our shift continued. Every piece of monitoring equipment connected to Marcus was providing readings that didn't correlate with his actual physical condition. The cardiac monitor showed one rhythm while his actual heart rate was completely different. Blood pressure readings were inconsistent with manual measurements. Even the pulse oximeter was giving us oxygen saturation levels that didn't match arterial blood gas results. But the most disturbing realization was that Marcus seemed to be aware of these discrepancies and was trying to help us understand what was really happening to him. When the blood pressure cuff inflated for automatic readings, Marcus would hold up fingers to indicate his actual blood pressure numbers, which we confirmed were accurate when we checked manually. It was as if Marcus existed in two states simultaneously. His physical body showed all the signs of severe trauma and neurological injury that our equipment was detecting. But his consciousness was operating on a completely different level, aware and alert in ways that challenged everything we understood about brain function and medical monitoring. Dr. Stevens made the decision to contact our chief of neurology for an emergency consultation. Dr. Patricia Hendricks had 30 years of experience in brain trauma and had seen cases that defied conventional medical understanding. When she arrived at Trauma Bay 7 at approximately 2:15 in the morning, Marcus immediately turned his attention to her before anyone had introduced her. Dr. Hendricks began her neurological assessment, but Marcus anticipated every test she was about to perform. Before she could check his pupil response, he was already preparing by opening his eyes wider. Before she tested his reflexes, he was positioning his limbs for optimal testing angles. It was as if he could read her mind and knew exactly what she was planning to do. "Dr. Hendricks, this patient is demonstrating awareness and cognitive function that should be impossible given his brain injury," Dr. Stevens explained. "His scans show severe trauma, but his responses suggest normal neurological function." Dr. Hendricks reviewed Marcus's CT scans and compared them to his responses during her examination. The contradiction between the imaging results and his actual behavior was so significant that she ordered an immediate repeat scan to verify the original results. While we waited for the new imaging, Marcus became increasingly agitated. He kept pointing toward the clock on the wall and making urgent gestures that we couldn't interpret. His vital signs, both the accurate manual measurements and the inconsistent monitor readings, began showing signs of distress. "Dr. Stevens, I think he's trying to tell us something time-sensitive," I observed. "He keeps looking at the clock and seems like he's trying to warn us about something." Marcus confirmed my observation by nodding emphatically and then pointing toward the doorway again. This time, instead of gesturing about other patients, he was pointing specifically at the clock and then at himself, as if indicating that something was going to happen to him at a specific time. The clock showed 2:45 a.m. when Marcus's behavior changed dramatically. His previously coordinated movements became erratic, and his attempts to communicate became more desperate. The equipment that had been providing inconsistent readings suddenly began showing rapid deterioration in all his vital signs. But here's what made no medical sense. As the monitors showed his condition crashing, Marcus remained fully conscious and aware. He was watching his own vital signs decline on the screens around him, and his expression showed that he understood exactly what was happening to his body. Dr. Stevens immediately began aggressive resuscitation measures, but Marcus was shaking his head and trying to communicate that something else was wrong. He kept pointing to a specific area of trauma bay 7, gesturing toward the corner where our emergency medications were stored. I followed his gestures and discovered something that made my blood run cold. The emergency medication cart had been moved from its standard position against the wall to a location that blocked the main electrical outlet feeding power to our life support equipment. The cart's position was creating an electrical issue that was affecting our monitoring systems and potentially compromising our ability to provide adequate care. Marcus had somehow recognized this equipment failure before any of our technical staff had identified the problem. His inconsistent vital sign readings weren't due to his medical condition. They were due to electrical interference caused by the poorly positioned medication cart. But even after we corrected the electrical issue and our monitoring equipment began providing accurate readings, Marcus's condition continued to deteriorate in ways that defied medical explanation. His physical body was shutting down according to every measure we had, yet his consciousness remained intact, and he continued trying to help us understand what was happening to him. The new CT scan results arrived at 3:20 a.m., and Dr. Hendricks called Dr. Stevens and me aside to review them privately. The images showed that Marcus's brain injury was even more severe than originally thought. According to the scans, he should have been in a deep coma with no possibility of consciousness or awareness. Yet Marcus was still alert, still responding to our voices, and still demonstrating medical knowledge that seemed impossible for someone in his condition. We were witnessing something that challenged the fundamental principles of neuroscience and emergency medicine. Dr. Stevens made the decision to transfer Marcus to our intensive care unit for continued monitoring. But as we prepared for the transfer, Marcus became increasingly distressed. He was trying to communicate something urgent about leaving Trauma Bay 7, shaking his head when we explained the transfer plans. Finally, we understood what Marcus was trying to tell us. He wasn't afraid of leaving Trauma Bay 7. He was trying to warn us that something would happen if he stayed. At exactly 3:30 a.m., Every piece of equipment in Trauma Bay 7 began malfunctioning simultaneously in biomedical engineering team had never seen before. The ways that our cardiac monitor started displaying heart literature. The ventilator began to exist in medical rhythms that dawned cycling at impossible rates. That's lungs should have damaged Marcus. Yet his oxygen disturbing was the IV levels remained stable. Most pump, which began infusing medications at rates that our programming couldn't account for, as if it was operating under commands that no one had entered. But Marcus remained conscious through all of this, watching the equipment failures with an expression that suggested he had been expecting them. He looked directly at me and mouthed the words, "It's starting," just as the room's temperature began dropping noticeably. Dr. Stevens immediately called for emergency maintenance, but when the technicians arrived, they couldn't find any mechanical or electrical problems with the equipment. Everything tested normally, yet the malfunctions continued whenever the devices were connected to Marcus. That's when Marcus did something that still gives me nightmares. He began accurately predicting each equipment failure before it happened. He would point to a specific monitor and hold up fingers indicating how many seconds until it would malfunction. Every prediction was correct, down to the exact moment. "The IV pump will stop in 15 seconds, Marcus mouthed, holding up his fingers. Exactly 15 seconds later, the pump shut down completely, despite showing full power and normal operation status just moments before. Cardiac monitor in 8 seconds. 8 seconds later, the heart monitor went blank, though Marcus's actual heart rate remained stable when we checked manually. Dr. Hendricks had been documenting everything, but even she appeared shaken by what we were witnessing. In 30 years of neurology, I've never seen a patient demonstrate this level of awareness while showing brain activity patterns consistent with deep coma, she said quietly. This challenges everything we understand about consciousness and brain function. But Marcus wasn't finished surprising us. As the equipment failures continued, he began providing detailed information about the mechanical problems that our technicians couldn't identify. He indicated that the cardiac monitor had a loose connection in the internal wiring harness that wouldn't be visible during standard testing. When the technicians opened the device, they found exactly the problem Marcus had described. He directed them to a specific component in the IV pump that had developed a microscopic crack in its circuit board. Again, Marcus was completely accurate. The ventilator had a software glitch that was causing it to ignore programmed settings, exactly as Marcus had somehow determined. How is he diagnosing equipment failures that require specialized training to identify? Dr. Stevens asked. He's providing technical information that even our biomedical engineers don't immediately recognize. The answer came when Marcus began demonstrating knowledge that went far beyond medical equipment. He started providing information about the hospital's electrical systems, structural engineering, and even administrative operations that were completely outside his possible knowledge base. Marcus indicated that there was a water leak in the ceiling above Trauma Bay 7 that was causing electrical issues throughout the room. Maintenance checked and found a small pipe leak that had been slowly dripping into the electrical conduits for weeks, creating the equipment problems that nurses had been reporting. But he also knew about things happening in completely different parts of the hospital. Marcus correctly reported that the elevator on the 4th floor was stuck between floors, with 2 maintenance workers inside. He knew that the pharmacy computer system had crashed, and that medication orders were being processed manually. He even knew that a pipe had burst in the basement, causing flooding in the hospital's mechanical room. Every piece of information Marcus provided was verified as completely accurate, describing situations he couldn't possibly have known about from Trauma Bay 7. "Dr. Stevens, I need to ask you something important," I said during a brief moment when Marcus appeared to be resting. "Have you ever seen anything like this before in your medical career?" "Never, Sarah. In 20 years of emergency medicine, I've never encountered a patient who demonstrated this level of impossible awareness. Marcus is providing information that suggests his consciousness exists independently of his physical brain function. As dawn approached, Marcus's behavior became even more extraordinary. He began communicating about events that hadn't happened yet, but which we later confirmed occurred exactly as he predicted. At 4:15 a.m., Marcus indicated that an ambulance would arrive in 12 minutes, carrying a heart attack patient who would need immediate cardiac catheterization. He gestured toward the main entrance and held up fingers showing the specific time of arrival. 12 minutes later, paramedics rushed in with a 58-year-old man experiencing massive myocardial infarction, requiring emergency intervention. Marcus had somehow known about this patient before the ambulance had even been dispatched. He predicted that Dr. Richardson from cardiology would be called in for the procedure, that the patient would need 3 stents, and that the surgery would take exactly 2 hours and 40 minutes. Every detail Marcus provided proved to be accurate. But perhaps the most unsettling aspect of Marcus's condition was his apparent awareness of his own medical situation in ways that defied explanation. He began providing information about his injuries that our imaging hadn't revealed, directing Dr. Stevens to internal bleeding that wasn't visible on our initial scans. Marcus indicated that he had a small tear in his liver that was slowly leaking blood, creating internal pressure that would become critical within the next hour if not addressed surgically. Emergency surgery confirmed exactly what Marcus had described, and the repair prevented what could have been fatal internal hemorrhaging. He also knew about neurological damage that our scans hadn't detected, describing specific areas of brain swelling that required immediate intervention. When Dr. Hendricks ordered additional imaging based on Marcus's information, she found precisely the problems he had identified. It was as if Marcus could see inside his own body and understand his medical condition better than our diagnostic equipment could determine. As we prepared Marcus for emergency surgery to repair his internal injuries, he became increasingly agitated about something he was trying to communicate. He kept pointing toward the surgical suites and shaking his head, as if warning us about some danger. "Dr. Stevens, he seems to be concerned about the surgery," I observed. "Maybe he knows something about his condition that we haven't identified yet." But Marcus wasn't worried about his own surgery. He was trying to warn us about a problem in operating room 3 where another patient was undergoing emergency surgery. Marcus indicated that the patient on that table was experiencing complications that the surgical team hadn't recognized yet. I contacted the OR and discovered that they were indeed experiencing unexpected difficulties with their patient, exactly as Marcus had somehow determined. His warning allowed them to take corrective measures that likely saved that patient's life. Throughout his time in Trauma Bay 7, Marcus continued demonstrating impossible knowledge and awareness that challenged every principle of medical science. He existed in a state that seemed to transcend normal human consciousness, aware of things happening throughout the hospital, and even events that hadn't occurred yet. But as the morning shift arrived, and we prepared to transfer Marcus to surgery, something changed. His extraordinary awareness began to fade, and he started responding more like a typical trauma patient with severe brain injury. The equipment in Trauma Bay 7 returned to normal operation. The temperature stabilized, and Marcus's consciousness seemed to settle back into his physical body, losing the remarkable perception that had characterized his entire stay in our department. Dr. Stevens, Janet, and I stood outside Trauma Bay 7 as Marcus was wheeled toward surgery, trying to process what we had witnessed during those impossible hours. None of us could provide a medical explanation for Marcus's condition or the phenomena we had observed. But we all knew that something had occurred in Trauma Bay 7 that night that challenged everything we understood about human consciousness, medical monitoring, and the nature of awareness itself. As I watched Marcus disappear into the surgical suite, I realized that my career in emergency medicine had been fundamentally altered by those hours in Trauma Bay 7. I could never again approach patient care with the same assumptions about what was medically possible or impossible. The room that had given so many nurses an uneasy feeling had revealed something profound about the nature of human consciousness and awareness that medical science wasn't prepared to acknowledge or explain. And I knew that I would never be able to work in Trauma Bay 7 again. Not because of what had happened to Marcus, but because of what his case had revealed about the limitations of our understanding of human consciousness and the mysteries that exist beyond our current medical knowledge. The surgery to repair Marcus's internal injuries was successful, but the surgical team reported something that made no medical sense. During the procedure, Marcus had remained conscious despite receiving general anesthesia that should have rendered him completely unconscious. The anesthesiologist, Dr. Rebecca Chen, had administered multiple agents at doses that would typically keep a patient under for hours. Yet Marcus continued to show signs of awareness throughout the operation. Dr. Chen documented that Marcus's brain activity monitors showed patterns consistent with deep surgical anesthesia, but he was clearly responding to verbal commands and even providing guidance to the surgical team about his own anatomy. When the surgeon encountered unexpected scar tissue from a previous injury that wasn't documented in Marcus's medical history, Marcus somehow communicated the location of a safer surgical approach that avoided critical blood vessels. Most disturbing was Marcus's apparent ability to observe the surgery from outside his own body. He accurately described the positioning of surgical instruments, the conversations between team members, and even activities happening in adjacent operating rooms. Dr. Chen had never encountered anything like it in 15 years of anesthesiology practice. After a successful 3-hour procedure, Marcus was transferred to the intensive care unit, where his impossible awareness continued. The ICU nurses reported that he could predict alarm sounds before they occurred, knew when medications were being prepared before anyone entered his room, and provided accurate information about other patients he couldn't possibly see or hear. But it was Dr. Jennifer Martinez, the ICU attending physician, who made the most unsettling discovery about Marcus's condition. While reviewing his case history, she found medical records indicating that Marcus had been declared clinically dead for 4 minutes following a construction accident 3 years earlier. He had been resuscitated successfully, but there was no documentation of any unusual neurological effects from that incident. Dr. Martinez contacted Marcus's previous discovered that co-employer and workers had noticed significant changes in his behavior after the accident. Marcus had begun demonstrating uncanny awareness of workplace safety hazards, predicting equipment failures before they occurred, and showing knowledge of construction techniques he had never been trained in. His supervisor had attributed these changes to trauma from his near-death experience. But now Dr. Martinez wondered if something more profound had occurred. When Dr. Martinez questioned Marcus about his previous accident, his response was deeply troubling. He explained that during those 4 minutes of clinical death, his consciousness had separated from his physical body and gained access to information that existed independently of normal human perception. He described experiencing awareness that transcended individual consciousness, connecting him to what he called universal knowledge that included understanding of medical procedures, technical systems, and even future events. Marcus claimed that ever since his resuscitation 3 years ago, he existed in a state where his consciousness could detach from his physical body during times of extreme stress or medical crisis. The motorcycle accident had triggered this separation again, allowing him to observe his own treatment while simultaneously accessing information about hospital operations, other patients, and equipment malfunctions throughout the facility. This explanation challenged every principle of neuroscience and consciousness research that Dr. Martinez had studied during her medical training. But Marcus's accurate predictions and impossible knowledge seemed to support his account, no matter how scientifically implausible it appeared. Over the following days, Marcus's condition stabilized physically, but his extraordinary awareness persisted. He continued providing information about hospital operations that he couldn't possibly know, predicting patient outcomes with uncanny accuracy, and demonstrating medical knowledge that would typically require years of specialized training. The nursing staff became increasingly uncomfortable caring for Marcus, not because he was threatening or dangerous, but because his level of awareness made them feel exposed in ways they couldn't explain. Several nurses reported feeling like Marcus could see into their thoughts and emotions, understanding their personal concerns and professional anxieties without any verbal communication. I visited Marcus during his recovery, hoping to understand what had happened during those hours in Trauma Bay 7. When I entered his room, he immediately looked at me and said, "You're thinking about requesting a transfer away from emergency medicine because of what you witnessed. You're questioning everything you thought you understood about consciousness and patient care." He was completely correct. The experience in Trauma Bay 7 had shattered my confidence in medical science and my understanding of what was possible during patient care. I had been considering leaving emergency nursing because I could no longer approach critical care situations with the same assumptions about consciousness, awareness, and the nature of human experience during medical crises. Marcus made a full recovery and was discharged 2 weeks later, returning to his construction job with no memory of his extraordinary awareness during treatment. But the experience changed everything for me. I transferred to outpatient care the following month, unable to continue working in emergency medicine after witnessing something that challenged the very foundations of what I thought possible. Trauma Bay 7 still operates normally, but I know that room holds secrets about human consciousness that medical science isn't ready to acknowledge. Sometimes there are experiences in healthcare that force you to accept that our understanding of life, death, and awareness is far more limited than we dare to admit. That night in Trauma Bay 7 changed my perspective on medicine forever. What I witnessed with Marcus challenged every principle of neuroscience and consciousness that I had learned during my 12 years in emergency nursing. His impossible awareness, his ability to predict equipment failures and medical complications, and his knowledge of events happening throughout the hospital defied every explanation that modern medicine could provide. The experience forced me to confront the uncomfortable reality that there are aspects of human consciousness and awareness that exist beyond our current scientific understanding. Marcus's case demonstrated that the line between life and death, between consciousness and unconsciousness, might not be as clearly defined as we believe in the medical field. I never worked another shift in Trauma Bay 7, and 3 weeks later I submitted my transfer request to outpatient care. Some experiences in healthcare are so profound that they fundamentally alter how you view the practice of medicine. What happened that October night was one of those experiences. To this day, I wonder how many other cases in emergency medicine involve phenomena that we dismiss as impossible because they don't fit our current understanding of human physiology and consciousness. Marcus recovered completely and returned to his normal life. But his case left me with questions about the nature of awareness that I may never be able to answer. Sometimes the most disturbing cases aren't the ones involving violence or tragedy, but the ones that force you to question everything you thought you knew about the boundaries between the possible and impossible in human experience.